Hello and welcome to our webinar series. My name is Adam Vieira and I'm with the National Training and Technical Assistance Center for Early Serious Mental Illness. We are just going to jump right in, but while folks are joining, please feel free to use the chat to introduce yourselves, share your name, where you're coming to us from, and a little bit about yourselves. Gonna just get started with a couple of housekeeping notes. So next slide, please. All right, so just in case you haven't noticed already, this presentation is being recorded. We will be making both the recording as well as the presentation slides available to everyone who's registered for this webinar via email in about a couple of weeks after the webinar. During the webinar, please feel free to submit your questions and comments in the chat or using the Q&A feature at the bottom of your screens. And if you have any issues, technological or otherwise, you can always private message folks who have Westat in parentheses at the end of their names. So without further ado, I am going to pass the baton over to our project director, Dr. Preeti George.
Thank you so much, Adam. And thank you everybody for attending. We're so excited to share this presentation with you on clinical high risk for psychosis and stepped care. This is a really important topic in service delivery, and we are thrilled to have experienced presenters today to share practical and relevant information that you can use in your work. So for our webinar today, we will have a slide presentation with information on stepped care and clinical high risk for psychosis. And then we'll have a panel discussion with grantees that are funded through SAMHSA's Clinical High Risk for Psychosis program. We will have a Q&A session at the end, followed by closing remarks. So I have the pleasure of introducing our presenter, Dr. Nicholas Breitbort. Dr. Breitbort is a professor of psychiatry, College of Medicine Distinguished Professor, and Vice Chair for Community Behavioral Health in the Department of Psychiatry and Behavioral Health at The Ohio State University, where he serves as Director of Epicenter, the Ohio State University Psychosis Program. He serves as a content area expert for the Global Burden of Disease Study on Schizophrenia, Major Depressive Disorder, Bipolar Disorder, Health Financing, and All-Cause Mortality. And he's a former member of the American Psychological Association Task Force on Serious Mental Illness and Severe Emotional Disturbances. Please welcome Dr. Nick Breitbort.
Well, thank you, Dr. George, for the kind introduction here. I'm happy to see all the names fly in on the chat where everyone is joining us from today here. Looks like a good group that is coming. Next slide, please. So today, the learning objectives will be to describe the concept of step care in the context of CHR-P programs, identify 3 points during the therapeutic process when assessment of treatment response is recommended, and identify at least 3 objective measures for determining treatment response among individuals at clinical high risk for psychosis. Next slide, please. So as Dr. George said, I'm Nick Breitbort, happy to join you all from The Ohio State University today here, and to talk about some of the great work that has been going on around the country here around providing step-based care for individuals who are at risk for developing a psychotic disorder. Next slide, please. So in the lore of psychosis research for a long time, the assumption was that illnesses like schizophrenia were what we called progressively deteriorating illnesses, where once the illness started, you got worse and worse and worse at a steady pace for the rest of your life, unfortunately, until you died. But as data began to accumulate about what the natural course of these illnesses look like, what we saw was not this sort of slow, steady decline throughout the course of illness, but rather a sharp drop right at the first onset of psychotic symptoms here, where within the next 2 to 5 years, on average, the majority of the negative outcomes that come along with psychotic disorders tended to cluster. This is when people were falling out of school and work, or having more hospital visits, were at elevated risk for suicide. These negative things clustered. And then after that first critical period here, things seemed to plateau. Now, this idea changed how we have begun thinking about how we treat these illnesses right here, and has sparked an international movement around early intervention, targeting folks in that period following a first episode of psychosis to try and minimize the challenges that emerge. Next slide, please. Now, in response to this, there's been an unprecedented dissemination effort that I'm sure many of you are familiar with this, with coordinated specialty care programs, specialized care services with multiple interventions targeting people who've had a first episode psychosis. These have grown exponentially across the United States, sparked largely not only by interest in this area, but by dedicated funding from SAMHSA through the mental health block grants that now states have to help individuals who are early in the course of a psychotic disorder. Next slide, please. So I'm coming back to this course of schizophrenia slide here, because if you look, it's great that we're intervening early, and the work on first episode psychosis in this country is amazing. And at the same time, you might notice that if we go a little earlier in this natural course graph here, there's another period before the onset of psychotic symptoms called the prodromal phase, a period of time where people begin to show at-risk symptoms for developing a psychotic disorder here. And the idea of a prodrome, this sort of running in period into an illness or at-risk phase, is not unique to psychosis. Many illnesses have these here, diabetes being one of the classic examples. People will sometimes talk about being identified as at risk for diabetes or pre-diabetic, depending on the term that they use. In psychotic disorders, we also see this at-risk or prodromal period right here. And if we are really going to intervene early, waiting until the first episode of psychosis is maybe not the most ideal time to wait until here. Why wait until the distress and the challenges that come along with an onset of psychosis emerge before we start intervening? And could we potentially intervene with people in this at-risk phase, not to minimize challenges that come with psychosis, but actually prevent these disorders from starting in the first place? Next slide, please. Now, there was initially significant question about whether it was appropriate to provide care to individuals early in a psychotic illness here, in this prodromal phase here, or what we now call the clinical high-risk phase, because for quite a period of time, there was no diagnostic criteria to identify these individuals with here. They hadn't yet developed a psychotic disorder here. But what we know about these individuals here is, while they may not yet have a psychotic disorder, and hopefully they won't develop one here, regardless, most of these individuals are under significant distress. Within this population of individuals at clinical high risk for psychosis, we see elevated rates of depression, anxiety, suicidality, trauma, and a group of individuals who are looking for someone to help them understand what is contributing to the concerns that they are experiencing here. So the idea of beginning to provide care to individuals in this clinical high-risk phase here is not just warranted because it could prevent an illness or a serious illness from occurring, but it's also something that individuals are typically looking for here. They are not feeling good in the world here and are looking for appropriate services. Next slide, please. Now, unfortunately, there's a lot of debate about what is appropriate service, and standards of care are still being developed for individuals in the clinical high-risk phase. To just highlight this a little bit more, this slide shows the current international recommendations in care for individuals who are at risk for developing a psychotic disorder. And what you'll see is that there's a lot of debate. There's no consensus about really what we should be offering these folks here. Where's the way to go here? I think most people think it makes sense to start with some sort of psychosocial treatment at the beginning, but what that is, how it's delivered, and how medications may or may not play a role in the treatment planning is still an area for debate and discussion. Next slide, please. So in this cloudy, murky arena, SAMHSA put out a call in 2018 asking programs to think about what we could do to offer treatment for individuals who are at risk for developing a psychotic disorder here. There was no clear set of best practices to do, but we had a group of individuals who were struggling, who needed care, and were struggling to find appropriate services here. And SAMHSA put out funding for agencies to begin to reach out into the dark and think about how they could best provide care for these individuals here, with the idea of not only minimizing the distress that they were experiencing, but for some to maybe potentially prevent a psychotic disorder from beginning, for those who unfortunately would continue to develop a psychotic disorder, to facilitate quick transitions to a coordinated specialty care program so that they could continue to receive the best care that they needed for their symptoms. Next slide, please. So in this call, the only recommendation or requirement that SAMHSA had was that each of the funded agencies provide what they called step-based care. And step-based care means we are going to start by providing someone with low-intensity evidence-based treatments, typically things that might not even focus on psychotic symptoms specifically, but may focus on other things such as depression or stress management. And we are going to repeatedly see how these individuals respond to treatment. Do their at-risk symptoms go away? Does their functioning improve right here? And the thought was, for some individuals, a low-intensity treatment may be all that they need at this point right here. And we would track, see if we could get their at-risk symptoms under control. If so, we could hold them at that low-intensity treatment. If not, we could then move them up gradually over and over again to more intensive, more psychosis-specific treatments until we finally achieve that treatment response. Next slide, please. So to give an example of what this might look like, this is the step-based care model that we use at Ohio State University. Individuals participate in, they can select from 1 to 5 different interventional tracks that they participate in. And they start with low-intensity services. And if they achieve symptomatic and functional response, great, work's done. Let's just keep an eye on them. But if not, we can move them up to more intensive services. So you'll see on our psychotherapy track, individuals there may start just with psychoeducation and work about reducing substance use. And for some individuals, that is all that they need to help get their clinical high-risk symptoms under control. But if not, and we see that those symptoms persist, we can move them up to a new treatment. In our setting, we use the Unified Protocol, which is a cognitive behavioral therapy protocol that targets depression and anxiety, not necessarily psychosis, but depression and anxiety. And for many individuals, that may be enough to help them achieve functional and symptomatic response. But if not, we can continue to move them up to a higher level of psychotherapy where we can offer cognitive behavioral therapy that targets clinical high-risk symptoms specifically, or even our metacognitive remediation treatment that targets cognitive functioning here. So we start with low-intensity, non-psychosis-specific interventions and can move all the way up to much more intensive psychosis-specific interventions if needed. Next slide, please. So as we assess response to treatment, we want to be thinking about the many different concerns that individuals at clinical high risk may be struggling with here. Of course, we're always interested in thinking about the attenuated positive symptoms, the subthreshold delusions and hallucinations that for many individuals are the crux of their at-risk experience here. And here, there are a number of different assessments that can be used. Our clinic uses the positive symptom subscale of the SIPS at every single clinical encounter to see if people are experiencing active attenuated positive symptoms or if these are under control. Many sites also use the mini SIPS, a shorter version of the SIPS that's been developed as well here too, that also focuses primarily on attenuated positive symptoms. But beyond symptoms, as I mentioned before, individuals at clinical high risk struggle with other concerns. Many of them are struggling in work and school and social functioning here. And there's often a use in thinking about tracking functional response here. Again, several scales are available that you could think about using to track this response in folks here to see how they are improving over time. Things like the personal and social performance scale and the social and occupational functional assessment scale are some examples of ones that can be used that are particularly useful because there are clinical cutoffs on these measures here where we can actually say not only is someone's functioning improved, but they move from being at a clinical level where they're struggling with their functioning in domain to doing very well and in a range that we would think is indicative of someone without any mental health concerns. Beyond that, though, as I mentioned before, individuals at clinical high risk struggle with suicidality, depressed mood, trauma, anxiety, all different mental health concerns that clinical high risk programs may want to consider using as their tracking response to their treatments. Next slide, please. Now, when we use these assessments here, these are not meant to be done when someone enrolls and then maybe every 3 or 6 months along the way here. These are really thought to be utilized as a session-by-session measure to see how individuals are doing here. And if we don't track these things session by session, if we leave large gaps of time between them, we will probably miss a lot of the concerns that individuals at clinical high risk are experiencing. So to give you an example of this, my colleague Heather Wassler here at Ohio State University looked at assessment of suicidal ideation among individuals in our clinical high risk program here. We assess this at every single clinical encounter that they come in here. And what really stood out from Dr. Wassler's work here was that if we had just asked people about suicide when they first enrolled and 4 months later, we would have missed over half of the people who reported any type of suicidal ideation during the time we were working with them. It was only by checking on this every single session that we were able to accurately assess this, to catch incidences where suicidal ideation appeared, and be able to respond to it appropriately. So when we think about the assessments in step-based care, it's not just tracking, but tracking frequently, as many of these things can change pretty rapidly among individuals at clinical high risk. Next slide, please. So with this in mind, SAMHSA funded 21 agencies as part of their first cohort here to reach into the dark and begin offering clinical step-based care to individuals at clinical high risk for developing psychosis. And since then, a second cohort has been funded as well here too to continue this work. We were lucky in Ohio with our partnership with our local Alcohol, Drug, and Mental Health Board of Franklin County to partner up to receive one of these awards here and begin offering this service in our community. Next slide, please. So does this work? Well, we are still reaching into the dark in many ways and trying to refine our care here. But the preliminary data about step-based care for individuals at clinical high risk is very promising here. Looking at data from our clinic here just at Ohio State University, Dr. Sarah Hamilton looked at time to achieving symptomatic and functional response among our individuals here. And symptomatic response was defined as having no active attenuated positive symptoms. Functional response, which we looked at using the PSP, was defined as being in the non-clinical range, which is a score of 71 or higher. It's a GAF-like measure here. And we were incredibly encouraged to see here that achievement of symptomatic response, getting those attenuated positive symptoms under control, and functional response was really the norm among individuals in our stepped care program here. Over 2/3 achieved symptomatic response, and they did it fairly quickly with a median time to achieving that of just 11 weeks. And just under 2/3 achieved functional response here, reporting levels of social and role functioning equivalent to individuals who are not struggling with a mental illness. And here, again, this was a rapid change, only about 9 weeks here. Now, this was able to happen despite the majority of our individuals not being on any antipsychotic medication, which to us really highlighted the benefit of this idea of step-based care. We were still able, using low-intensity interventions, to help people achieve symptomatic and functional response here, and only had to use things that may have potentially concerning side effects like antipsychotic medication for those individuals who truly needed it and who may not have benefited without it right here. As a bit of a teaser, the team at Westat, led by John Cosgrove, is in process of putting together a report looking at similar outcome data for all of the clinical high-risk programs funded in that first SAMHSA cohort. And that data should hopefully be coming out here soon to continue to show the exciting work that is coming out of this area. Next slide, please. So as we think about these services here, we have still not yet perfected treatment for individuals at clinical high risk for psychosis. Step care offers a useful and potentially more beneficial service than was available, but there's still many ways we can get better and questions we need to think about. For example, how do we optimize our treatment options here? For example, I showed you previously what our stepped care model looked like in 2018. Next slide, please. But now we've changed it a little bit right here, adding in peer support, for example, as a service for our individuals here, adding a more formal psychoeducation program into what we do. We are constantly refining this here to try and think about what is the best care option for individuals at risk for developing a psychotic disorder, as are all the other programs, to think about how we can optimize care and maximize response to these treatments. Next slide, please. As always, we are reaching out to think about engagement and retention strategies. How can we get more people in the door? And when they're here, how can we make them want to stay and see value in the services that we offer? Discharge planning here. For individuals who may not move on to a coordinated specialty care program, for those who don't go on to develop a psychotic disorder, how long should they stay in care? What is the service that they should receive afterwards here? This is still an area where we're beginning to explore and understand how best to address the needs of our individuals. And of course, the context and location of these programs here, putting them in academic medical centers and community mental health centers, even thinking more about the neighborhoods where they may be right here. How can we make these programs as accessible as possible to those who need them? Next slide, please. So with that, in this introduction here, I'm happy to turn it over to a number of leaders of exemplar clinical high-risk programs across the country, all of whom have been funded by SAMHSA dollars to stand up step-based care programs. And all will share about lessons that they've learned and the differences in their models here, so that you all can appreciate the range of options that are available here. There's no one right way that we know of here to provide step-based care to individuals. And everyone has figured out important pieces of the puzzle that we'll get to hear a little bit more about today. So among our distinguished speakers will be Rebecca James and Sarah Lynch, joining us from the PEER program in Maine, Jessica Malkin, joining us from the Utah Department of Health and Human Services to talk about efforts in Utah around clinical high-risk care, and Dan Shapiro from UC Davis Early Psychosis Program to share about their work with their clinical high-risk program. And with this, I'm delighted to turn things over to our leaders of these exemplar programs to share the lessons that they've learned with the work that they do.
Okay, good morning. Thank you, Dr. Breitbard. And my name is Rebecca James, and I'm presenting on the Community Hope and Resources for Psychosis program, which is part of the PEER program of Portland, Maine. And many people know us from the PEER program as part of the PEER Training Institute that does CHR-P-related and FEP-related trainings outside of the state of Maine. So wanted to recognize that. And also, before we get going, I want to recognize Bree Mazzelli and Stephanie Farquhar, who are both on this call and represent the Maine State Office of Behavioral Health overseeing this grant, and Sarah Lynch, who is the PEER program manager, also on this call as well to be able to assist with questions and answers. So one thing in Maine that makes our intervention here unique for early psychosis is that we have quietly and steadily actually been providing 25 years of early psychosis treatment, starting with CHR-P services way back in 1999. And we've done that partially through research opportunities and through internal mechanisms. So that's gone in some ways under the radar screen, but currently we have 2 FEP programs in our state that cover the whole state, and the CHR-P program that I'll be presenting on today. So as part of those 25 years, we have a rich network of referral sources and a long history of community outreach. So in beginning this grant, we didn't have a problem getting referrals to our treatment team, and that allowed us to be able to really focus on implementation of the stepped care. So I'm going to begin by just describing the levels of care that we provided and created as part of this grant. We have 5 levels of care, which increase in intensity based on the P symptoms that were assessed using the SIPs, based on functional impairment and based on, safety concerns. So ranging from level of care 1 at the lowest level, where essentially we complete the SIPs and refer out to appropriate providers and close the CHR-P assessment, noting that any early psychosis concerns are either not distressing or not progressing or recurring, and we refer out. On the high end level of care 5, these are folks who we've identified presence of psychosis, and we transfer seamlessly to our FEP team, which again is under the same umbrella. In the middle is where we have our CHR-P programming, and the lowest of the CHR-P assessments is level of care 2, which is our workforce development goal. This is crucial. This is where we're providing ongoing assessment through the ongoing reassessments through the grant, but we are recommending services to be provided by a psychosis-informed provider in the community that we're consulting and engaging with over time. Levels of care 3 and 4 both involve some acquiescence of services on the CHR-P team. On level of care 3, that's what we called selective components of the full coordinated specialty care model. And what we think of internally as the most complicated level of care, because we initially described it as related to number of services on the stepped model. We'll get into that later. Level of care 4 is the highest CHR-P level of services, which is full coordinated specialty care from the CHR-P team. And again, levels 2 through 4 are all reassessed every 6 months. So 2 years in, we've completed 60 intakes since the start of our program. We've been very busy. Our mean age of folks coming in is 16. And of those, 60% are female at birth. As folks stratify into the different levels of care that we just described, we have about 60% consistently over year 1 and year 2, 60% of those stratifying into levels of care 3 and 4, which are limited or full CHR-P services. So for us, that's important because it's a good, efficient use of assessment and services. Going into level of care, going into year 3, we've intentionally pared down our pace of intakes and assessments to 24 per year or 2 per month. And notably, on the one hand, that's above what we anticipated when we wrote the grant, which was 10 to 15 assessments per year. So that's been very helpful for us and crucial for sustainability planning with Medicaid and billable services being able to be greater than we expected. But it's also been important to be able to create a sustainable pace moving forward, as we had a large backlog of people waiting for services. So of our referrals coming in, we had 50% of our referrals from our outpatient mental health clinics, 25% and growing from primary care, and a growing number of self, family, or community-based providers referring, which was 20% in year 2. So this parallels our outreach efforts, and that for us was a good sign. I also want to note that it's not that we're not receiving more referrals from more acute setting, it's that these are being routed more appropriately through our FEP team. So we're really able to focus on the community. Secondly, we've spent some good time paying attention to the other diagnoses that people came into our program with. So 40% of the folks coming into our program had a previously diagnosed mood disorder, and 60% had a previously diagnosed anxiety disorder. So this became important to us as we were focusing on EBPs that were included CBT for psychosis or CHR-P, but also included CBT for depression, anxiety, and trauma, which became more crucially important. So a note on our reassessments as we're going, 6-month reassessments. At the time that we pulled the data, we had a significant, statistically significant reduction in P symptoms between baseline and 6 months. We also had a reduction of depression and anxiety scores across the board. At 12 months, we had the reduction in P symptoms continued to stay at a lower level. But interestingly, and this is where we paid close attention, depression scores remain the same, and anxiety scores actually increased from our baseline scores. So that was initially perplexing for us, and it brought up a lot of questions that we've been learning along the way, and I'll just touch on them now, and we can address them more in the Q&A if that makes sense. But some questions raised by us is one, is like when psychosis stabilizes, as it often does in 6 to 12 months, how can we determine when to step clients out of psychosis specialty services? And Dr. Breitbart has referred to this as well. For us, after stabilizing psychosis, other things would begin to emerge and additional treatment needs would remain unmet if we solely went by our levels of care. Also, engagement at the level of care 3 versus level of care 4 varied widely. So one person might come in at level of care 4, but be relatively unengaged and not utilizing many services offered. Somebody else at level of care 3 could be very engaged and wanting more services than they were technically eligible for. Lastly, again, as Dr. Breitbart mentioned, the psychosis-informed care resources at level of care 2, part of our workforce development, were more limited. They didn't uptake as quickly as we had hoped, which means discharging down to level of care 2 or reducing to level of care 2 became increasingly problematic and increasingly required the need of case management at that lower level of care. So defining levels of care by number of services became significantly problematic for us. So going into year 3, we did some quality checks and we've reinterpreted how we're doing things similarly. It's an ongoing quality improvement process. So now instead of looking at number of services between level of care 3 and 4, we essentially look at formulation, and we've shifted to modules of treatment. So now for us, everyone begins with psychosis-informed care with a CMES introduction and family psychoeducation, including, and this is important to us, a short-term exposure to multifamily group, all in 6 months or less. Then at 6-month assessment or before, we start to proceed on the evidence-based practice for anxiety, depression, trauma, or early psychosis, which is CBT-P adapted from CBT-P. So our hope is that these treatment exposures will be more consistent across the board with what folks are getting coming into the program, and that it'll emphasize short-term exposure to psychosis specialty care, and it elevates the importance of the 6-month and 12-month and ongoing assessments and formulation-based treatment outside of CBT for psychosis and CHR-P, ultimately making the length of treatment shorter at the lower levels of care. So of course, this depends on many factors, but we feel like we're moving in the right direction. And that's all I have. And either Sarah Lynch or I will be available in the Q&A portion for any further questions. Thank you.
Thank you, Rebecca. My name is Jessica Macon. I use she, her pronouns, and I am a program administrator here in Utah in the Department of Health and Human Services within the Office of Substance Use and Mental Health. My role at the state level is over transition age youth and employment supports, and that includes our early psychosis programs, both CHR-P and FEP. Go ahead and go to the next slide, please. Our teams here in Utah are called Prevention and Recovery from Early Psychosis, so PrEP. This is our brand new logo. We also have a website that just went live last week that I will share in the chat when I'm finished. And we have been operating our services, first episode psychosis services starting in 2015 with the block grant set-aside dollars. And then we received our first round of CHR-P funding in 2018 and second round in 2022. I have the opportunity at the state level to provide oversight to our teams across the state. If you'll go to the next slide. So just to give you an idea of where our teams are located in Utah, since I imagine most folks on this call aren't familiar with Utah geography, our mental health system is a county-led system. So the Office of Substance Use and Mental Health operates as a pass-through to the local mental health systems at the county level. So we have a team at Weber Human Services, at Weber and Morgan counties up at the top, Davis Behavioral Health in Davis County, Volunteers of America in Salt Lake County, and then Wasatch Behavioral Health, which is in Utah and Wasatch counties. So those systems, like many public public mental health systems operate a variety of services across kind of Medicaid required services. And that includes our first episode psychosis program, clinical high risk program, which are co-located together into these prep teams and provide services across their assigned counties. Next slide, please. Our sites have learned a lot through the past 6 years. Similar to what Rebecca discussed, we have our stepped care model that kind of walks through the different stages. Very similar across the span of shared decision making with the young person and the family, monitoring emerging psychosis symptoms and other mental health symptoms, offering peer and family support, psychoeducation, managing substance use risk, and then moving along as needs arise with CBTP, individual placement and support or supported employment services, supported education, coordination with crisis teams as needed, as well as occupational therapy. We have occupational therapists at each site. And because Weber Human Services and Davis Behavioral Health are close together in geography, they actually share an occupational therapist between the two sites because those population areas are smaller and those teams only spend kind of part of their time providing this service to their community. We've really learned over these years that within the context of stepped care, the team really has to come together for those weekly team meetings to coordinate and discuss services. That collaborative approach is such an important part of making sure that the young people that we're working with and their families are getting the services that they need, because there's a lot happening in these young people's lives. They're going to share different things with different service providers, and that coordination is really important. And the team model also provides that opportunity for different messengers across the team. I think really normalizing that for young people, for all of us, there's going to be people that we like better than others, and that's going to be the same for service providers. And so really keeping that in mind, that it may not be related to the symptoms they're experiencing necessarily, but just the fact that they're a young person and they may like one person better than another. With the stepped care model, clients can always change their mind about the services that they want and need, and we really work to be flexible within that process in order to ensure that they are staying engaged, and to make sure that the team and the client and the family are on the same page and really working toward that communication being consistent. Community education isn't part of the stepped care model, but I wanted to kind of point out community education, which is part of the CHR-P grant. But it really is critical in the work that we're doing, because not everybody knows that that clinical high risk is something that they need to think about. Next slide, please. Like I said, all of our sites are co-located with FEP programs so that if a young person does experience a first episode of psychosis, then they can continue remaining with that team and receiving services. And it just helps with that continuity of care. And also, because 3 of our sites are located within the public mental health system, if a young person finishes the program, they can be transitioned to other services within the public mental health system, which is really nice, because then that prep team is available if they need them in the future. Next slide. Engagement is a significant focus on the front end, as with all services. We've definitely noticed that even as people come in, they meet criteria for CHR-P, it can be tricky in those first 6 months to keep folks engaged. And we've built in some flexibility at the beginning of that time to ensure that we give folks the opportunity to adjust to this new service that they're experiencing in a lot of different service providers and a lot of new information for the young person and their family. Next slide, I think, is mine. Also being really clear about making sure that families know that the program is time limited from the start. Of course, building in flexibility if somebody is in crisis and they're at their end of their time, we're not going to discharge folks. We're going to, use our clinical judgment and discharge folks appropriately, but really being clear about that from the beginning with the goal of making sure that the family understands that if you're finishing the program, that's a good thing. That means you're managing your symptoms, you're managing your mental health. We're always here if you need us. And having lots of conversations about transitions and next steps so that families are really clear about what their options are, and the young person is really clear about the services. I will be around for questions at the end if folks have questions about how things work here in Utah, but I will pass it over to Dan.
Hi, everybody. Good morning from sunny California. I'm really excited to be here today to talk to you about our Skip Step program, which is a partnership between our early psychosis programs here in the Department of Psychiatry and Behavioral Sciences at UC Davis, as well as the Sacramento County Department of Health Services. Next slide, please. In particular, I wanted to talk about stepped care, the promise of stepped care for scaling up expert services for those at clinical high risk for psychosis to the local population level. Imagine attempting to identify and treat people at the level of your county, or at least at a healthcare system level. And in particular, stepped care models can really help you be thoughtful about how you scale up expert care to address some of the really common barriers we encounter in trying to do that kind of implementation work. These are certainly not all of the barriers. These were some of the ones that we encounter the most that we tried to be thoughtful about in developing our system here. So, if you imagine trying to identify everybody in a local population who's showing signs and symptoms of risk, you need to make sure that the eyeballs who interact with those young people know what to look for. And these are typically not people in healthcare roles, right? Once you've identified people, we also think about availability of the skills we would need to address those signs of symptoms, really to know how to work with these things. And if you're thinking about scaling up over a large population, right, we start to think about lots of people. The other kind of difficult thing at a health system level is really the heterogeneity of this at-risk state. So we are talking about a risk syndrome that is probably pluripotent in the sense that demonstrates multifinality, right? So you have people identified now who really are on different trajectories, and you don't know that until time passes. So you need services that can be flexible and responsive over time. We also have a population where some folks who have risk symptoms have symptoms that are not so impactful on their daily life and maybe sort of a low level of care, outpatient might work. And you have folks who are experiencing lots of other things, right? Or might have symptoms that require daily care, in-home care, right? Or signs of risk, and so on. So services also need to be flexible in that sense too, right? Very different needs. And then, of course, workforce issues are big ones with this population. So in community health, we are often talking about a workforce that comes and goes, that has turnover, and often is not quite sufficient to meet everybody's needs. Next slide, please. I'm not gonna talk too much about Sacramento. I think we are quite similar to many counties. We have about 1.5 million people. We have one specialty early psychosis clinic, one clinic really with the goal of identifying and treating those at risk. So this is certainly not the case in more frontier or counties with lower populations, but we do not have the capacity to think about identifying everybody amongst that 1.5 million people. Next slide, please. So our care program, what we've developed is an effort to take a relatively small number of people from within our early psychosis clinic and sort of go to community level agencies. So we have embedded a two-pronged approach, starting with universal screening and then training staff in local non-specialized clinics to implement or give a 2-year stepped care intervention where people are assessed by our team every 6 months. And for those who still meet criteria for clinical high-risk syndrome, they receive sort of increasingly specialized or skilled interventions over the course of time. So we're currently in 9 clinics across 5 different community mental health agencies. The other really nice benefit here is that we hope that over time, not only are we reaching lots of people, but we are then helping to train this workforce who either will stay in those clinics or potentially move elsewhere in the Sacramento community with some of these skills. So just very briefly, we start with screening for everybody that walks in the door. We're currently screening about 50 intakes per week. So these are screenings done by community level staff. Our team comes in, we use the mini SIPs. We do a little bit of assessment every 6 months about satisfaction with treatment, outcomes in terms of real life and symptoms and a couple of other things. Basically, in the first 6 months, people are integrating with these multidisciplinary community teams. We're not doing a lot of specialized work other than providing assessment and feedback. At 6 months, they begin getting a CBT package called CBCM. Generally, this starts with general stress management. For most folks, it's really focused in the early stages on more generalized skills that lots of people can treat. Think anxiety, depression, sort of managing things. At 12 months, we start to involve prescribers as best we can. So we introduce consultation for therapists at 6 months. At 12 months, for those who are still meeting criteria, we incorporate interaction with their providers, with their psychiatric providers. And then at 18 months, we introduce some additional assessment to look at what might still be maintaining risk for folks who are still in the program. Next slide, please. The idea here is that at any reassessment, those who are no longer meeting clinical high-risk criteria, they exit the program, but they stay embedded with these exact same care teams. The goal of providing services in their own community, which tends to be more accessible, which we hope is more affirming. We think community care, you're likely to get care by people who share culture, right, who sort of understand lots of things. And if you develop psychosis at any point here, you then get kind of a fast pass to our one early psychosis clinic here at UC Davis, which may not be embedded within someone's community, right? So it involves sort of a handoff. Next slide. I'm happy to answer questions about workforce when we get to the Q&A. I just wanted to point out, this is our team. Really, I think what we've tried to key in on here is a relatively small number of hours of our expert team here to really try to reach a very large number of people throughout our county. You can see our goals at the bottom. I'll leave it at here. I'll leave it at this. I have a slide in here which I'm happy to chat about, showing their workforce here in our county, predominantly folks who have, next slide, please. Predominantly folks who are relatively new to their professions, or relatively new to their agencies, a large number of clinical staff who have not yet received their license. And so we are also thinking about the different levels of care. Sometimes people switch clinicians, right? But a way to sort of triage the level of skill and expertise with this sort of increasingly specialized interventions. Thanks very much. Lots of thanks to our big teams here.
Yes, I echo all of the thanks. Thank you to all of our presenters and panelists, and thank you to all of the different participants who've been sharing questions in the chat and in the Q&A feature. We are going to take the next 10 minutes almost to hopefully answer most of these questions, but we do have quite a few, so we might not get to all of them. So I just want to say that we have been tracking the questions, and if your question isn't answered during the webinar, we will be reaching out to you after the webinar with a response from our presenters. So just know that even if you don't have your question posed here, we will get to it at some point. So thank you all, and please feel free to keep the questions coming. I know that there's a lively chat happening in the chat, and just want to kick us off with our first question, which is, can you please say something about psychosis rates amongst autistic people and people with autistic spectrum disorders who are high functioning with or without being an ADHDer, and rates of psychosis compared to other populations? So I don't know who would like to take that. I will pass the baton to whoever wants to start.
Well, I can start off the discussion on that here. I think there's sort of 2 points. One is, yes, rates of psychosis among individuals with autism spectrum disorders are elevated compared to individuals without autism spectrum disorders. And at the same time, disentangling symptoms from psychosis from autism can be very tricky. And many of the things that we see, especially in the clinical high risk phase, where maybe delusions and hallucinations are not fully formed, can also be similar experiences to what someone with an autism spectrum disorder may experience as well here too. Jason Schiffman has written a number of really wonderful papers about effective assessment to try and tease out what experiences may be better explained by autism spectrum disorders versus those that might be better characterized as clinical high risk symptoms here. And I always recommend his writings as the go-to when you're trying to disentangle that question.
Thank you for that response, Nick. And I'll just add to that, that if you're interested in more information about screening, diagnosis, and risk assessment in the context of clinical high risk for psychosis, we had a webinar last month on that topic, and it will be available through our website. It is not currently available, but we are hoping to get it up there shortly. So thank you for that. And thank you for the response. Would anyone else from our group of presenters like to respond to that question before we move on to the next one?
I might add one thing as we think about stepped care. I think you often think about steps as like only going in one direction, up, increasing in intensity. One of the benefits of thinking about a stepped care model is that this is a risk syndrome where there are lots of comorbidities. The step is sometimes over and not up. So one benefit is as you get to know people over time as providers, regardless of diagnostic categories, you better understand their needs, the intensity of their needs, the things you do well and the things you need help with. And so I think that a longitudinal model kind of gives you the, yes, right. Just adding, it gives you the opportunity to better refine the needs that individual people have over time, which you don't usually know when you first meet them.
Thank you, Daniel. And Sarah, it looks like you are
Yeah,
off mute.
I just wanted to add just that we have an Autism Center of Excellence here, and it's it has our clinical high risk program and first episode program. We've had, we've referred to them and they've referred to us through our assessment. So, I mean, I would just second what Dan says about just that I think as a system, we end up, referring and collaborating better across programs with this, with this kind of stepped care model.
Thank you, Nick, and thank you, Sarah. Thank you, Nick, Daniel, and Sarah for responding to that question. We're going to move on in the interest of time to another question, and we're kind of skipping around. But the question that another person posed was about the billing codes, HCPCS codes that you're using to help identify if a client is receiving stepped care services in a timely fashion.
Oh, Sarah, if you want to go ahead, please do.
Well, I was just saying, we haven't integrated the new. We're working towards a case rate for first episode psychosis here in Maine, and we're using standard outpatient billing codes and hoping to move into figuring out how to, for the people that are on the higher end of needing more of a sort of wraparound case rate service, we're trying to look at that and how to accommodate that. But our first step is a case rate, and then and we're looking at service utilization within this stepped care to learn better how to cover it and how to make it sustainable.
Thank you, Sarah. Nick, did you want to add to that?
I was going to say the same thing for us in Ohio. We just utilize standard outpatient therapy mid-management CPT and HCPCS codes for our work as well.
Thank you both for your responses to those questions. We are going to pose one more question before we begin wrapping it up on our end, which is, how can you learn about peer support for these psychosis programs?
Go ahead, Dan. You were first.
I believe you were first.
So polite.
I think so. How can you learn about peer support for these programs and kind of the role around peer support? There's a couple of we coordinate with the Early Assessment and Support Alliance in Oregon as our technical assistance provider, and they have some excellent education on their website and some modules that we use for training for peer support. I know for us, for peer support, it's tricky to find a perfect match, because finding a peer support specialist who has lived experience with psychosis is not always an easy find, nor is it always an easy find to have a peer support specialist on your teams, right? So I think really prioritizing having somebody with lived experience within the mental health systems to make sure that they can help the young person navigate those pieces, and really normalizing the fact that a lot of this work is around managing your mental health, right? Managing your mental illness systems that we all have to work through, whether we have a diagnosed mental illness or not, right? And so really utilizing that kind of normalizing experience within the context of peer support. So whether you have a peer support with lived experience with psychosis or not.
Thank you, Jessica.
I mean, I was going to say something very similar. I think we, in Sacramento County in California, we have the benefit of really nice support for peer services and for billing for peer services. This population is a little bit tricky because right, this might be a different peer workforce than those who have lived or living experience of psychosis. And so, yes, just really to second, thinking about people who have sort of any lived experience of receiving services in a similar model or setting as yours is a really nice way to start and really valuable. I think on our teams, we try to use both youth peers, so those who themselves, right, have lived or living experience, as well as family peers. This is a very young population, right, who often is still living with families. And so support for parents and other family and care providers is equally valuable.
If there's enough time, I'll just add quickly that it does, with good outreach and connections over time, peer support becomes more and more available. We look to hire people with lived experience onto our team members and work with graduates through the peer support mechanism to be able to stay in contact with them after clinical services have ended. And that is crucial for getting lowering stigma about early psychosis in general and about building access to people with lived experience in a more effective way.
Thank you, Daniel and Rebecca, for responding to that question. We are going to close it out now by just sharing some upcoming events that I think will actually help answer some of the questions you all had. So we know that several of you posed questions in particular about the use of marijuana, but the use of substances more generally, and psychosis. And so we will be having our webinar next month, February 18th, on early serious mental illness and substance use. And that'll be presented by Drs. Melanie Bennett, Corinne Kaczmarek, and Samuel Murphy. We will also, following that in March, have a webinar on suicide prevention best practices for individuals at clinical high risk for psychosis or experiencing first episode psychosis. And then in April, we will have a webinar on cognitive health in the coordinated specialty care context. So with that, I just want to thank you all for being here. Please continue to show the next slide so that we can make sure that everyone has access to the webinar evaluation. We would love any feedback and thoughts you have to share. And for those of you whose questions weren't answered, just a reminder, you will be hearing from us from the ESMI TA Center with a response to your questions. So stay tuned. Thank you all and have a lovely day.